This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
All right. Good morning, everybody. So over the weekend, we had a really bad burn that came in. So I thought it was a good time to kind of review some of the stuff that we do for bad burns. We see a lot of burns that are kind of being transferred to us because they're sensitive areas or they need to see a burn surgeon eventually. This was a burn that presented primarily to us, and it was pretty impressive. The initial estimation was he was about 92% of his total body surface area. He had sat in his car and doused himself in a gallon of gasoline and then intentionally lit himself on fire. Some of the stuff that we have to think about in these patients, when they come in, the first thing that we're thinking about is our ABCs. We want to do this just like a normal trauma. He didn't crash the car. There were good witnesses. The patient was actually awake and talking. So pretty quickly, some of the things that we need on our trauma survey, we could kind of rule out. He didn't need a C-spine, that kind of stuff we could work through initially. One of the things is because this is a very enclosed space, inhalation injury has to be really at the top of our list. So the A of our ABCs, this is an airway that we want to take really quickly. We had the team prioritizing that because he was so burned. We had a really hard time getting IVs, and even the IVs that we were getting were just getting pushed out of the skin as that skin started to thicken up and become really difficult to get access through. One of the things that Stephen did, just immediately went and grabbed an IO, which was great. It gave us access really early. It's painful for patients to have an IO, and we did give a little lidocaine so that we could start giving some medications, but it was the only access that we had for a really long time, and it was the one that we ended up using the most reliably as other things became kind of pushed out and not usable. In terms of circulation, initially on evaluation, we did check pulses. He had pulses everywhere. Those quickly became a lot harder to find because of all of these circumferential burns. And this is a patient that ultimately had to go for Escharotomy, meaning they're kind of cutting the sides of all of his extremities and digits. He ended up actually developing, because he had a circumferential burn of his entire torso, at some point, even after intubating him and putting him on positive pressure with really high PEEPs, like PEEPs 16, 18, he was really difficult to ventilate. And so eventually part of his Escharotomy actually had to be on the chest as well. But that's something we want to watch out for here in the emergency department. Exposure, we got to get these patients exposed. We got to make sure we kind of have a sense of how much the burn is. These patients are going to get put on fluids. We like lactated ringers to avoid that hyperchloremic metabolic acidosis that they can get from normal saline. We used to do a lot of fluids in these patients. We used to use a formula called Parkland. We have gone to a modified Brook formula. Basically, all that means is for us here in the emergency department, we are starting fluids, we are starting lactated ringers. Because we are a burn center, a lot of the cognitive offload of how much fluid and how fast the fluid needs to go, a lot of that goes to our burn surgeons. So we want to start these patients on the appropriate fluid. We want to make sure that that's kind of cooking, but we don't slam patients with fluids like we used to. It can lead to intra-abdominal compartment syndrome, problems with elevated intraocular pressures. You can end up in real trouble by over fluid loading these patients. So no slamming fluids, but enough. In the absence of trauma, these patients shouldn't be hypotensive. And then kind of our last sort of thing, when we first went to go intubate the patient, I had asked for rock, and that's kind of part of my old training, that if you're intubating someone who's had a burn and it's been kind of a while, because they can get hyperkalemic, succinylcholine is not a medication that you want to use. And kind of going back through and looking at that over the weekend, it's actually fine. It's fine to use Sux in an early resuscitation. I think it was helpful to have him paralyzed while we were kind of doing some of our resuscitation, but it's helpful to know either is an option.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.